My task today is to talk about the approach and the management strategies in patients with heart failure. Most of us are involved in managing a patient with heart failure in one way or another, and most of what I'm going to say is not new for you. The challenge is not in the knowledge itself. The challenge is in the actual practice, having the patients on the appropriate medications and the appropriate doses as recommended. Chronic heart failure is estimated to affect more than 25 million people worldwide. It's an increasing, growing burden on healthcare facilities worldwide. The prevalence is expected to grow at a rate of about 2.7% per year, and the absolute mortality rates for heart failure remain approximately 50% within 5 years of the diagnosis. 30-day post-mortality rates decreased from 12.6 to 10.8 between 1993 and 2005 in the U.S. due to lower in-hospital death rates. But the post-discharge mortality increased at the same time frame from 4.3 to 6.4%. So it is an increasing burden, whether it is in repeated hospitalizations or in mortality that we have been seeing. In Saudi Arabia, the Hearts Registry looked at a population of hospitalized patients with heart failure, those acute heart failure patients, and there was a chronic arm which is not published yet. But we do know that similar to worldwide, most of our heart failure patients are secondary to coronary artery disease, more than 55%. Then followed by dilated cardiomyopathy as a second etiology, and then hypertensive heart disease, and to a lesser extent, the valvular heart disease. In our echo reports, when we looked at the ejection fractions of these patients, you can see that most of these patients have LV dysfunction, which we also refer to as HFrEF, or heart failure with reserved ejection fraction. Those with preserved ejection fraction were about 27%. This might be selection bias because these are cardiologists who are following these patients, and most of the patients coming to us as cardiologists are in the LV dysfunction or HFrEF category compared to our colleagues in internal medicine or other specialties where they might see more HFpEF. When we looked at the chronic arm, we did have quite similar, but interestingly, the etiology was halfway between ischemic heart disease and dilated cardiomyopathy, then followed by hypertensive heart disease. Again, the HFpEF population was only about 12%. So we are still in even though we see them in the emergency room, probably we don't follow them up in the outpatient. Most of our patients are the reduced ejection fraction patients. And let's say probably because they are easier to manage. Most of us have very difficulty managing the HFpEF patients, and we don't have strong data or evidence to guide us in these patients compared to the HFrEF population. So what I'm going to talk about today is the management strategy of patients with heart failure and reduced ejection fraction. I just want to remind you with the American College of Cardiology American Heart Association a classification where they reminded us that heart failure is actually a continuum and not the classic heart failure stage C, the ones who present with the classic signs and symptoms of heart failure and have the strongest evidence. You need to consider those before they develop this classic symptoms, even at the stage where they only have comorbidities like hypertension, diabetes, obesity, and those who develop an insult to their heart, whether they had an MI, but they never actually developed the classic heart failure signs and symptoms. So you can, that increased the awareness of the whole public and the whole sector and the continuum of healthcare practitioners in this field. Then I'm going to touch on the stage D patients who, with all your optimum medical therapy that you know about, they're still symptomatic and not feeling well. The classic, you all remember the blocks of heart failure management, ACE inhibitors, beta blockers, your diuretics, the steroid antagonists, digoxin, and your devices. But let me remind you of some of the data that made us think or put these in actual blocks of priorities. We know from long time, from the 80s, that ACE inhibitors in several trials, classically enalapril in asymptomatic, those with moderate heart failure or advanced heart failure, ACE inhibitors still showed significant reduction in morbidity and mortality, and that's why it has been recommended as a standard of care in heart failure patients. So ACE inhibitors, according to several guidelines, are recommended for routine administration in symptomatic or asymptomatic patients with ejection fraction of less than 40%. All patients should be on that. Again, the challenge is remembering it and remembering to titrate the patients to the targeted doses, not just putting a patient on enalapril 2.5, and some of us just use it once a day and say that I'm really managing my heart failure patient. That's the real challenge, to remember to go up to the targeted doses. So that's why in the guidelines, it was mentioned clearly, should be titrated to doses used in clinical trials as tolerated, reminding you that enalapril, for example, the dose is 10 to 15 BID for patients with reduced ejection fraction. Then the angiotensin receptor blockers, which are classically alternatives to ACE inhibitors, and we know the two approved ARBs in heart failure are the valsartan and the candesartan. Those are the ones that have the data, the Valiant and the CHARM trial. And ACE inhibitors, although remain the first choice for inhibition of renin-angiotensin system, ARBs can be considered as a reasonable alternative. But individual ARBs, as I said, may be considered as initial therapy rather than ACE inhibitors for patients with the following conditions. Heart failure with post-MI heart failure. Valsartan has evidence post-MI heart failure, could be the first choice if you want to use that. And chronic heart failure, reduced ejection fraction, strength of evidence B. So if you have a patient already on ARB for another indication like hypertension, there is no point in switching him to ACE inhibitors because it comes first. You can keep him with a very strong evidence of improvement. Second, beta blockers. We all know the strength of beta blockers in heart failure. The three approved beta blockers in heart failure are bisoprolol, metoprolol, extended release, and carvedilol. Now, please remember that it's not a class effect, so don't put your patient on atenolol or any other beta blocker and think that you have done him good. Don't put your patient on metoprolol, short-acting, tartrate, and consider it as an alternative. It has to be the extended release or switch to something like bisoprolol or carvedilol. And that because of the data. There is actually a recent study of comparing even the metoprolol extended release to carvedilol, and they were similar. But those, you remember the carvedilol or metoprolol trial where carvedilol was better than the metoprolol short-acting. As I mentioned, these are the three ones that are approved in heart failure. Then comes the hydralazine nitrates. We have two main indications for this. Those are who cannot tolerate ACE inhibitors or beta blockers because of their kidney dysfunction or hyperkalemia. And also, classically in African Americans, if the patient is still symptomatic on maximum ACE inhibitors, ARBs, you could have it as an addition to these. The combination of hydralazine nitrates works very well, and it actually is probably even better in symptomatology compared to ACE inhibitors, but as an outcome, ACE inhibitors are still better for mortality. So treatment with a combination of hydralazine plus nitrate in patients with heart failure and reduced ejection fraction who are unable to take ACE inhibitor or ARB, and patients with persistent New York Heart Association class 3 to 4 and ejection fraction less than 40% despite optimal medical therapy. What about mineralocorticoid antagonists? Classically, we still remember the RAILS trial and the indication of RAILS trial. So if you ask anyone about the indication, he'll say persistent class 3 to 4 on optimal medical therapy. We forget the trials that came after that. We forget the emphasis in post-MI and the emphasis. Patients who come with post-MI heart failure or diabetes mellitus and an ejection fraction less than 40% should be considered for ARBs. Worldwide, there is a lack of use of, for aldosterone antagonists. There is only about 30 to 40% utilization of this drug, even in indicated population. Now, aldosterone antagonist receptor antagonists are recommended in patients with New York Heart Association class 2 to 4 and who have an ejection fraction less than 35% or less to reduce morbidity and mortality and must be considered. They are also recommended to reduce morbidity and mortality following an acute MI in patients who have ejection fraction of less than 40%, who develop symptoms of heart failure or have diabetes mellitus. So even if you have a patient now post-MI and our diabetes is very prevalent, it's up to probably 60% of our patients with heart failure or coronary artery disease. If you have a patient post-MI, just having, with a low ejection fraction, just having diabetes, even if he doesn't have signs and symptoms of heart failure, should be considered for mineralocorticoid antagonists. So please remember that. Now, so that's how it made it to the guidelines with this algorithm clearly. Remember, all patients with ejection fraction of less than 40%, symptomatic or asymptomatic, should be on ACE inhibitor, ARB, or an ARB plus a beta blocker. Then, according to the symptoms, if the patient is volume overloaded, you would consider diuretics. If he is persistent symptomatic or African American, you would consider hydralazine nitrates. And if he is class 2 to 4, provided good creatinine and potassium, you would consider aldosterone antagonist. Now, I know this drug is struggling in Saudi, but just approved recently in the US, ivabradine has been shown in the SHIFT trial to reduce death from heart failure. I'm sorry, the graphs are not showing, but there was about 26% reduction in death from heart failure, and it made it to European guidelines and soon to the American guidelines as a class 2A. Any patient with ejection fraction less than 35% and heart rate remaining above 70 beats per minute and persistent symptoms despite treatment with optimal doses should be considered for ivabradine. And if he cannot tolerate beta blockers, which is your main medication for heart rate reduction, should be considered ivabradine. And that's why in the European side of cardiology algorithm, after you consider your ACE inhibitors, beta blockers, mineralocorticoid antagonists, and your heart rate is still above 70, you need to consider something like ivabradine for management. I want to touch on something recent and might be a real shift and a change in the practice of heart failure. We all know, as I said, the effect of ARBs, ACE inhibitors, beta blockers, mineralocorticoid antagonists. These are all neurohormonal blockades, the classic diagram that we know. But we also need to remember our natriuretic peptides. These are, from its name, natriuretics. They are also vasodilators and have been shown a significant effect on the patient symptomatology and probably outcomes. This natriuretic peptide is being broken by an enzyme called neprilysin. So it reduces its effect in the body, and a new drug has been discovered to inhibit this enzyme and making your natriuretic peptides more abundant and more active in the body. As I said, the function, this trial, the paradigm heart failure, included patients with New York Heart Association class 2 to 4 and a persistently elevated pro-BNP or rehospitalization, and on optimal medications of ACE inhibitors and beta blockers, and aldosterone antagonists were also considered. And surprisingly, or unsurprisingly, we found a significant 20% reduction in death or heart failure hospitalizations, and a 20% reduction in cardiovascular death. We also found a significant reduction in sudden cardiac deaths alone, whether the patient had an ICD or not, and a significant reduction in worsening heart failure. So even those patients who did not have a death or mortality, their heart failure was less likely to progress and worsen. So now this might be the new standard of care, and I'm not saying might be, it should be the new standard of care, and we'll make it to the guidelines soon. If you have a patient who is symptomatic on ACE inhibitors, beta blockers, you should consider switching him to the valsartan sacubitril, the LCZ 696, because it has the strong evidence of a reduction in mortality and hospitalization. Now, because the talk touches I was asked to touch on both the medications and devices. We all know that, as you saw in the ESC algorithm and other algorithms, if the patient persistently is symptomatic, and that's the classic, if the patient has a wide QRS, low ejection fraction, and is symptomatic, you should consider biventricular pacing or CRT. And the strongest indication actually we have are in those who are symptomatic class 2 to 4, ejection fraction less than 35%, QRS more than 150 with a left bundle branch block, a pattern in sinus rhythm. These are the strongest indication for these patients, whether CRT or CRTD. And then the others, whether they have they're not in sinus rhythm or the QRS is from between 120 and 150, have a lower evidence, but they might be still indicated according to your patient. Let me remind you of the stage D from the ACC AHA classification, those with advanced heart failure. We don't call them end stage anymore because we do have options for them. These are the patients who have persistent symptoms despite optimal medical therapy, and they constitute about 5 to 10% of the population, and they consume more than 60% of the healthcare expenditures for heart failure, although they are a minority. The definition, the classic definition, severe symptoms and recurrent episodes of fluid retention, objective evidence of severe cardiac dysfunction like an ejection fraction less than 30%, severe impairment of functional capacity, whether it's on a 6-minute walk test or a peak VO2 max, and recurrent hospitalizations, more than 1 per 6 months or 2 per year, and presence of previous features of intolerance to guideline medical therapy. So one of the criteria is to be intolerant to beta blockers or ACE inhibitors because of worsening hypotension or kidney function and these things. These patients are advanced and should be considered for advanced therapy. When should we consider that? How soon or how late is something like that? The sooner, the better. When they get sick, they really succumb fast and they lose it. You need to consider advanced therapy. The best option, of course, is heart transplantation with a half-life of about 11 years and conditional half-life of 14 years. Some patients are more than 25 years. But again, the donors are very limited, and you need to consider some other alternatives. I will probably need 1 more minute if the moderator's allowed. One more minute?
You're fine.
Because it's going to turn off. The advance, when we have shortage of donors, shortage of transplants, you need to consider something else. That fueled the interest in the assist devices that really take your blood from the heart and pump it to the whole body. Started initially with pulsatile technology, now with continuous flow devices. These have shown significant improvement. These are types of devices that we have, the HeartWare and the HeartMate, where you just puncture the heart and it pumps the blood to the rest of the body. You might need biventricular support. We have the total artificial hearts too, which are also in practice. These have been used as bridge to recovery. Some patients post-myocarditis, peripartum cardiomyopathy might recover. You just support them until they recover. Or bridge to transplantation, which has been the most common use in the past. Destination therapy for someone who's not indicated for any transplantation or recovery, he will live with it. Some people have been living now for 9 years on these devices and are actually refusing transplantation. They're very happy with their devices. Or sometimes bridge to decision when you don't know what to do. As I said, in the past, the most common condition was bridge to transplant. But now, look at this. Most common worldwide is the destination therapy, not actually the bridge transplantation or bridge to recovery. And it had shown significant, of up to around 50% survival in 4 years. And we should have a low threshold now thinking of these devices because of the advanced technology and the effect of it. Thank you for listening and open for questions.